Let me warmly welcome all the viewers watching this program live from all our social media portals, YouTube, Facebook, Twitter, LinkedIn, and also webinar. So as usual, there's a number flashed on your screen. If you have any questions, please share your questions to us, and the distinguished speakers readily agreed to answer to all your questions. The only request is please make sure that your focus of the question is relevant to the subject what we are discussing, and not outside the subject, because I know the subject will attract lots of questions. We are anticipating, we are well prepared for that, but is a personal request, please share your question which is relevant to the theme. Now what's happening next few days is tomorrow, the 15th of June, we already got full house. I think if you're not booked it, still you can do it. I think few seats are still left. The journey of a champion, and the three champions are going to talk to us at MMA. One is Viswanathan Anand, the former Indian chess grand world champion. Geet Sethi, former billiard champion. He was a 9 times world champion, billiards. Then Ren Reskuna, Olympian hockey captain. So this year are going to be talking to us on the journey of a champion, because very rarely you get an opportunity to listen to some of the outstanding sports personality to come and speak. And if you are really learn something from them, I'm quite sure it will do quite a lot of good to you in your career, wherever you are. Maybe a corporate leader, you're a student, or an entrepreneur, it will be very, very good to you. Please come. Very rarely you get an opportunity. If you're not able to come, not to worry. From your home comfort, just watch all the program. You can go to my website. It'll tell you all the channels which the program is available for you. You can watch it live in all the channels. On 20th of June, again, we have a nice event, more focus for the students, that a guide to wealth and happiness. Again, we have three outstanding panelists, Babu Krishnamurthy, then Chandrasekhar Kupperi is the founder of Innova, and also Rajesh Devraj. It's happening on 20th June. Please do come on 20th evening. It's happening all in person. On 23rd June, again, not to be missed event. Again, we almost through there. We already got more than 150 nominations registered for this event. It's a paid program. Seminar on real estate, agile, accounting, GST, and IT and legal. This is all about construction industry we are discussing. What exactly it matters, be it GST account, how to maintain accounts, how to deal with direct taxes, how to deal with capital gains, and how to do some of the collaborations, what you do in joint ventures. And also we are discussing about green building and sustainability in one of the sessions. And Dr. Ilangovan is going to be talking to us on safety in construction industry. He's the Secretary Labour from DGFLI. He's going to be talking to us from Delhi. Then we also have Mr. Saravanan, principal of RERA, he won't talking to us. So it's a very, again, a very high-profile event, not to be missed. Then on 26th, again, very interesting subject, very, very relevant. Most topical is the urbanization, social change, development, and the Tamil Nadu experience. Again, three outstanding speakers we have. Dr. Purnalingam, IAS, the former Secretary of the Government of India. We got Vijay Bhaskar, Professor, Madras Institute of Management, that is MIDS, and also Anju Mary, she is the Director of Industry Affairs, Communication, and Sustainability from Danfoss. This is again an issue which is bothering many on sustainability issues of urbanization. Please do come. You'll get some great insights, especially for our corporate leaders, more so for the entrepreneurs and students to understand what exactly is impacting happening. Some of the statistics you see, you'll really get shocked what's happening in terms of urbanization. I think it's good to know what's happening. The last event for the month is 28th of June. Again, a great event, Conclave on Generative AI, the future is here. This again, not to be missed. We got some 21 outstanding speakers from around the world is going to be talking to this event. And in the inaugural session, we have Gopi Kalyali, head of Google, talking to us from San Francisco. Then we got also some of the other speakers talking from different areas. We got specialists who will be talking to us. I know how many of you know Jasprit Bindra, and if you read articles on Mint and a couple of other magazines, Jasprit is the authority on artificial intelligence. He's going to be talking to us. What are the 5 important changes going to happen with generative AI? He's delivering the keynote address. Jasprit Bindra is talking to us from I think UK. Is the Cambridge. Then we also have sessions on cyber security, and the authority on cyber security is going to be there. Generative AI. Then we have a panel discussion with some 5 outstanding panelists picked up from some of the best industries, Zogo, Kissflow, and some of the best, Institute of Analytics, USA. They'll be talking to us the application of generative AI, how it's going to change the job profiling of many of the industries, many of the individuals, how you can upskill, reskill yourself to meet the challenges. Please do come. This is again a paid program. We just charge for the food, what you're going to be eating, and some miscellaneous expenditure. I think it's for members, very, very 1,500, including GST, for a full day event. So do come. And coming to today's event, I am singularly very happy because we're able to bring this, present to you this event. Very, very important event because this is a subject which is not only applicable to ophthalmology, and I know it will be applicable to many things, because the speaker will tell you more about the subject, sensitivity and specificity of ophthalmic practices. And it's going to be a very, very interesting subject because this is a subject very rarely discussed. And I am very delighted, honored, because some of the professionals come and speak on this is very, very important. Normally, nobody speaks on this because it's a subject which everybody gloss over, move on. Ladies and gentlemen, put your hand together to welcome one of the finest ophthalmologists in India, I can even say in Asia and world, Dr. Arulmozhi Varman, Chairman Medical Director of Uma Eye Clinic, and to chair, we have our own Siva Kumar, who is member of the managing committee. May I request Dr. Arulmozhi and Siva Kumar to please take your place on the dais, sir. Ladies and gentlemen, a very warm round of applause to our distinguished speaker for this evening. Before I request Siva Kumar to take it forward, also introduce Dr. Arulmozhi Varman, let me briefly introduce Mr. Siva Kumar. You all know Siva Kumar very well, and it doesn't need introduction, but when I get the opportunity, it's always pleasure to introduce him and speak about his profile. It's so inspiring and so inspiring to read and listen. So many of you will really be envy to emulate of profile like Siva Kumar. Siva Kumar is the Director, Roots Industries India, Managing Director of RV Industries, Prabha Associates, Time Links, and many more companies. And he is a strategic thought leader, quality driven, passionate about serial entrepreneur. He's nearly redefined the perception of small and medium industries in the manufacturing space, and especially around asset light manufacturing, apart from guiding his retail organizations towards an innovative and customer centric excellence. He has done number of accolades and is also a winner of the national award for the India Inc. India Award for the top 100 people watched out for the excellence in HR practices. Good friend, great supporter of MMA, and we did a lot of work together. The beautiful building, what we made is part of our construction committee. Did some phenomenal work in bringing this building. That itself is a great story. Over to you, Siva Kumar. Thank you for willing to chair this session. Ladies and gentlemen, let me present to you Mr. Siva Kumar.
Good evening, and thank you, Group Captain, for those nice introduction on the activities of MMA and also introducing me to the audience. And the speaker for the day, Dr. Arulmozhi Varman. Many of you know him well. Many of you would have visited his clinic. Members of MMA, ladies and gentlemen, and people who are watching it live from different parts of India and different parts of the world. Welcome to you, to each one of you, for being part of this great evening. Now, doctor is going to be speaking to you on sensitivity and specificity of ophthalmic practice. Before he speaks to you, I thought I must introduce him to you. Now, Dr. Arulmozhi Varman is a leading ophthalmologist, eye surgeon in Anna Nagar, Chennai, with an experience of 38 years in his field. Dr. Arulmozhi Varman completed his MBBS from the Madras Medical College in the year 1980. Later, he acquired his postgraduate diploma in ophthalmic medicine and surgery from the Madras Medical College in the year 1987. What's very important is he holds a brilliant academic record of having secured the gold medal for topping the MBBS examination. And if that's not all, he also secured the first place in his postgraduate diploma in ophthalmic medicine and surgery. There's some more to the doctor which I'll tell you. Dr. Arulmozhi Varman is not only an astute clinician, but also an experienced instructor. He has traveled across many countries to perform and teach phacoemulsification cataract surgery. A master of phaco and extensive experience, he has conducted over 150 phaco training programs in India and abroad and has successfully trained more than 300 surgeons including those at the American Society of Cataract and Refractive Surgeons. Now, there are many times I have come and introduced the speaker. This is the first time I'm reading without my specs. This is basically because I went for a small surgery with the doctor last May or June, and he said, you don't need the specs anymore. And I asked him, how long will it take for you to do the surgery? He said, probably 15, 20 minutes. And then what do I do? How many days do I stay back at home? He said, no, you come in the morning, you can go to the office. So that's a nice word that I heard from him. Not only the medical words that you would speak, but also comforting somebody who's coming into your clinic and saying all is going to be well in a few minutes. And the day when I was supposed to go for my surgery, I got up in the morning with so much of joy because I'm going to be besides this doctor for 15 minutes. There's some great energy that he spreads across his clinic, across to every patient who comes across. So all of us are lucky today to have him here. And over to you, doctor.
Good evening. First, thanks to the MMA, particularly Captain Vijay Kumar and Mr. Shiva Kumar for asking me to be here. It's a pleasure to be here and talk to you about the specificity and sensitivity in ophthalmology. The first question comes up is, what does it mean? So whenever you have a technocrat coming and talking to you, he or she would talk about the advancements in that particular field. But what does this sensitivity and specificity mean? It's quite simple. Medical tests are just increasing. Diagnostic procedures are proliferating. And they're getting better. They're also getting expensive. So when you have a whole bunch of diagnostic procedures that are being thrown at us, how does the doctor choose a particular procedure? I'm not talking about treatment at all. I'm now only talking about diagnosis. That itself is getting to be pretty expensive and pretty extensive these days. So how does a doctor do that? So that is when they look at the sensitivity and specificity. Sensitivity means the ability of a test to accurately identify a person with a disease or a disorder. The specificity is the one that will say that the person does not have the disorder. So you have to have both of these two should be of a high percentage before you can pick up a diagnostic procedure and have it applied to a particular patient. So true positive is when you have a test, the person who undergoes the test has got the disease, and the test accurately diagnosed it. A true negative is when you've done the test, and the person who does not have the disease, the test said he does not have the disease. A false positive is when the person does not have the disease, but the test has wrongly diagnosed the person. That's pretty much risky. We don't want anything that's sensitivity less than 92%. Because anything less than that, you do 100 patients, you're going to diagnose 8 patients wrongly. The same way, false negative is a person who has got the disease, but the test is so porous, it says the person does not have the disease. So that's important. So we need to understand this about every diagnostic test, and then look at the prevalence of that particular disorder, then look at the demographic prevalence of the disorder, then apply the test to that particular demographic group. At that particular age or demographic group, then you will get better positive results and less people who will go into the dustbin either as negatives or positives. And we want to have more and more non-invasive tests. When I mean non-invasive, very easy, you can understand. You go for an X-ray, that's non-invasive. But the X-ray actually invades your body, that's an issue. You go for an MRI. MRI is absolutely safe, it does not do anything to you. Any number of MRIs you can take. So that's non-invasive. But if you put in a dye to do an angiographic MRI, then it's an invasive procedure. You put in a dye to look at the kidney, then it becomes invasive. Why does it become invasive? Putting in a product into the body, and there are people who will react to it. So these issues also count. So we want to have more and more tests which are absolutely non-invasive, but can give you results which were so far done only by an invasive procedure. So I've taken 3 diseases. I'll tell you why I took them. Keratoconus for a particular reason, glaucoma and diabetic retinopathy because it's highly prevalent. Diabetes is probably India today has the dubious distinction as having the largest number of diabetics in the world. And unfortunately, we also have a whole lot of diabetic complications. We'll come to that. Glaucoma will tell you. Keratoconus is very interesting, simple. We'll come to the diagnostic tool that's common to all of these. Something known as optical coherence tomography. We all know CAT scan, which is computerized axial tomography, where we use X-rays and get slices. Now, the eye is transparent, the cornea is there, so you use light itself. And this light source can give you sections of the eye, just like you would see on a CAT scan or MRI. So this is how you can see the whole eye if you wish to. This unbelievable details that you can make out. You can look at only the anterior part of the eye. The accuracy here is in about 3 microns. 1 micron is 1,000th of a millimeter. So 3 microns is the resolution of this instrument. You can look at the retina. So this is the interesting part. I'm not sure if you can see this thing. The retina has 10 layers. Normally, to see the 10 layers of retina, you have to have this particular tissue, which is from a person who's already passed away. Then you have to put it into a section, you have to dye it, then you have to put it under a microscope, and then only you can make this out. But here you can make out the 10 layers. This is layer 1, that is layer 2, layer 3, layer 4, layer 5, layer 6, layer 7, layer 8, layer 9, and 10. And this is on a simple projection. And on a higher resolution, you can actually look at every single layer very clearly. And each layer has got either cells or it's got nerve fiber bundles. Today, this technology can actually count the number of cells on the retina and tell you what is the count per square millimeter. That means you can know if there's a dropout of cells or the nerve fibers, you can count it. That's the level of accuracy that we've gone to, and it's totally non-invasive. It's another picture to show the accuracy where you can look at the retina very, very clearly. Here comes another one I'll tell you about where we all know about Doppler. The Doppler's explanation is very simple. You stand on the railway track, the train comes in with the horn on, the tone changes. As it comes in, it gets compressed. As it leaves, it gets elongated. The tone completely changes. So any moving object can, by the Doppler effect, you can trace the moving object using Doppler. That's how you do Doppler of the carotid or the vertebral arteries and say what is the blood flow there. But here, the ingenuity of human mind or the brains, we use the Doppler using light source. And you can delineate the blood vessels brilliantly. And that's taken on to a completely different level. So here I like to just digress. There's only one thing that exceeds human ingenuity, that is human greed. So how do we use diagnostics using the OCT? So this is where we come to keratoconus. This is the normal shape of a cornea. This cornea is thinned out and is bulging. Very clear? This is just a line diagram. So there are people who develop this disorder known as keratoconus. Mostly this is inherited disorder. Comes out in the teens or the later part of age. It can be worsened by allergies and by active rubbing of the eye, but otherwise it can just present itself as a natural course of the disorder. How are we diagnosing keratoconus all this while? We have to look at the eye sideways and look at that funny looking bulge. To be able to catch this bulge on a slit lamp or by the naked eye, the eye has to bulge almost 1 millimeter, 2 millimeters. That means the disease is already very, very advanced. Or you make the patient look down and see that the lid takes on a funny shape. These are the diagnostic ways that diagnosis was done when I was a PG in the 80s. There was nothing else, no other way of doing it. Another way of looking at it was somebody has high astigmatism, high cylinder power that kept changing, and poor vision. Oh, then you say, oh, this person has got keratoconus. And nothing more. Keratoconus is pretty prevalent in India and in the Middle Eastern countries also. So diagnosis here, you could only diagnose it in advanced stage. Now with the OCT, as I told you, the resolution is 3 microns. So when there's a 10 micron difference in the thickness of the cornea, or the shape of the cornea, because we know that you can look at the shape of the cornea very, very accurately. You can catch the disease. That means the disease is easily caught at a very early stage. As far as keratoconus is concerned, as I told you, it's progressive. As it progresses, vision drops. Eventually, we have to do only keratoplasty. We take out that cornea and you take a donor cornea and sew it on. So that was a pretty much a difficult surgery with not so good outcomes. There are a lot of issues in this, though the keratoplasty is one of the most successful transplants known to mankind. But now we can prevent this from occurring by doing certain treatments which will strengthen the cornea and prevent it from becoming weaker and bulging. So that's called collagen cross-linking. I will not go into that. And I told you I will not talk about treatment. But to do the treatment, you have to catch these patients early. Late in the disease, you can't. So this is where you have, I'll skip the prevalence part. You have these tests which is coming off from the OCT that I showed you. On this patient has got a small little doubtful island there, and you can diagnose keratoconus. The other person has got on the back of the cornea, he's got early keratoconus. So at this point, when vision is still good, this person can be diagnosed and a laser treatment can be done which will prevent the progress of this disorder. And you will prevent this person from literally going blind or going in for a very, very difficult, long-drawn surgery. So diagnostic formulae were all developed. So you just can't put on the machine and the machine is just going to give you raw data. Algorithms have to be developed to get to the diagnosis. So we had multiple groups of people. This is just one group that I'm putting out the names: Rabinowitz, KISA index, KPI score, KCI, Bellin-Ambrosi, enhanced ectasia. So you have groups of people, scientists have been working on this and coming up with algorithms, taking raw data from the OCT and giving you a result. Why would they do that? As management consultants, you know that money makes everything work. Nobody is going to do unless this product can be installed, sold, and money can be earned. So finally, come back, nobody was really interested in keratoconus until, I'll skip that also. Let's go back to the accuracy. Here is the accuracy of this. These topographic devices are accuracy to the specificity of 98% and sensitivity of 92%. So that's really good. He would have, normally at the age of 16 or 17, glass power stops changing. So a person who's got keratoconus would be rapid changes in glass power, blurring of vision, and changes in power in the cylinder actually, astigmatism. So the complaint there would be only vision. By the time the patient has got extensive complaints, it's already too late. You can't do much, you'll have to go for keratoplasty. So you have to catch it early. So early diagnosis would help preserving vision and preventing surgical intervention. But how did this whole thing, this is the question I want to come back to. What made diagnosis of keratoconus bloom and fructify into something that's phenomenal? Simply because a whole lot of patients were willing to undergo laser treatment. That is LASIK or now that SMILE. That's where the laser treatment remove the glasses. You can do it on a person who's 18 years plus who's wearing glasses, and if the person's cornea is stable, everything is good, you do a 5-minute laser procedure, no glasses for lifetime. But when you started looking at these, you look at the cornea very, very carefully, you started catching keratoconus. So coming back, unless there's money in something, the industry does not do any study into a particular pathway unless there is some other spin-off from that. Keratoconus by itself was not a money-spinning entity. It is not the whole entity of research, and the pathway research takes is very less held by technocrats now. Because the doctor literally does not have the role to take the direction of research. A research can be started off unless that research is going to be funded. Funding does not come in unless there's going to be a future to that product. And this is how you find keratoconus was a spin-off from LASIK. So this is a lesson to be learned as to how there are several molecules, several technologies in the pipeline will probably not see the day of light because they are not going to be financially successful. So technology today, it's a very sad fact that it follows money. Then we come to diabetes. So I told you, India is the largest diabetic population in the world. Depending upon the demographic pattern, in the Western literature, it says that almost 30 to 40% of people with diabetes tend to develop diabetic retinopathy. While the Indian demographic data says the percentage is a little lower. In some of the studies, it's as low as 15%, and some it's as high as 25%. So we can take a median as around 20% of people with diabetes will develop retinopathy. That means if you have 100 people with diabetes, 20 will develop retinopathy. So this has to be caught because this is a silent disease. At least in keratoconus, the patient will have blurring of vision, he or she would come up here. It's absolutely silent. By the time the vision starts to blur, it is absolutely too late. So we have to catch it very early. This is how a normal retina looks, and this is a very early diabetic retinopathy. At this particular point, the patient will have almost no symptoms. Vision will be probably 100% normal, but you find there are leaking blood vessels, there is some bleeding out there. And this person will be unaware of the issues occurring inside the eye. By the time it goes to very advanced of this stage where the vision is down, it is very difficult to do anything about the already lost vision. You can prevent further loss of vision by treating appropriately. And in diabetic retinopathy, it's sometimes difficult to get back what is lost. Not always, but most often. So it's very important to catch it very early. So the prevalence, as I already told you, it's been quite demographically different between, again, the urban population and the rural population. But I would say the Indian population now is somewhere about 20%. What is the underlying disease? Diabetes affects blood flow. That is it. Whether it is the eye, the brain, the heart, or the foot, anywhere, or the kidney, it is only blood flow that is impeded at the capillary level, not at the large vessel level, capillary level. And once that occurs, blood starts to leak out there because new capillaries try to form to overcome the blocked areas. The new capillaries that form are not as structurally strong as the normal capillaries or the normal blood vessels. They start to leak. They first leak serum, then they start leaking blood. Then you start having all kinds of complications. They're not able to supply oxygen to the tissues in spite of new vessels forming. And the old vessels are blocked. So that's the underlying pathology wherever you in the body. It doesn't make a difference. The advantage, the most important thing about the eye circulation, the retina, this is the only blood circulation in the human body that can be physically observed directly. So this assumes a huge amount of importance. I'll come to that as I go along. Huge amount of importance. So the way that we were looking at the blood flow until recently was, you can't look at the blood flow. You can look at the structure, but I won't know how the blood is flowing through it. We had to inject a dye. It's called fluorescein. Inject the dye, then take photographs, serial photograph. This is the way that we used to do this. So fluorescein angiography was done, but we were not doing it frequently because it's an invasive procedure. A certain number of people who develop allergy to it can faint, they can have even a cardiac arrest sometimes. So whenever you do fluorescein angiography, you would have a nurse standing by, anesthetist standing by, a doctor standing by, emergency drugs all kept ready, though it's probably 1 in 10,000, but still that's a risk. And you could have somebody, you could have to keep doing these tests repeatedly. How frequently are you going to do these tests? Every month, every 6 months, every 3 months? Not practical. So fluorescein angiography was something we were doing, but we were not doing it very frequently or not frequently enough to follow up a patient very meticulously. This is how the fluorescein angiography will look, where there's no blood flow in some areas, it's all blocked off. And this is some areas where there's absolutely no blood flow. The dark areas, there are no capillaries at all. You see the capillaries here. So this is the basic pathology of diabetes, particularly in the eye. So what if you were able to see this blood flow even better than the fluorescein, using no fluorescein, no invasiveness? So you come to Octa. As I told you, the OCT with angiography, which is using the Doppler principle, using light, not sound. So you see the beauty of this. It's far more accurate, far more details that are available. You can see the ground glass up here. This is a normal patient where all the blood vessels are perfusing. This ground glass appearance shows that all the capillaries, which are in between, are all completely open and everything is fine. So this you can do once in 24 hours if you wish to for a patient. Absolutely risk-free, absolutely nothing at all. Put the patient on the machine, it takes about 3 to 5 minutes and you know where you are. So it can be repeated any number of times with no risk involved at all. And then you see this is where diabetic retinopathy, where complete dropout of blood vessels in those areas, abnormal blood vessels coming up here, this will start to leak. unless you treat this and rectify this, this person is going to progress to really bad diabetic retinopathy disease. So now you have the ability, in a matter of 3 to 5 minutes, just not even putting drops in the eye. Sometimes putting the drops helps get a better picture, but this can be done even without putting in drops. So you really have a non-invasive procedure, which is brilliantly accurate to diagnose early retinopathy. Then it comes to how many patients am I going to put this machine on or the patient onto the machine. If I see a diabetic patient, we tell every patient with diabetes to come back every year. Are we going to put every patient on this? Or are you going to put only people who you think have some kind of a problem by looking at the patient with the microscope that we use normally called slit lamp, and then only put this on? That's the question to be answered. Very, very difficult question to answer. So then you have algorithms for this. So if you have a patient whose sugar is well controlled, and he or she is only about 3 to 5 years of diabetes history, known history, maybe the chance of developing retinopathy is low. Anybody over 10 years should have this test done every year. That's no question. Anybody between 5 to 10 years, poorly controlled diabetes, then they should have this test done every year. In spite of all that, if I do 10 patients, I'll probably catch 2 or 3 patients with the disease. That means we are doing more procedures than what is probably warranted. That's how it looks outwardly. But when you do serially, a person every year, year on year, you can catch that person's disease very easily down the line. So this is where cost comes into play. One of these kind of machines, the low-end machine, which has got low resolution, costs only 75 lakhs. The high-end machine will cost 1.5 crores. So then the patient also has to bear the cost. The doctor bears the cost, the patient. Like I say, none of the machines that I have are mine. They're all yours, because you're the one who's paid for it, not I. That's what it boils down to. It's the patient eventually who's paying for everything. It's not that the doctor owns it. The doctor is only looking after the machine and using it for the betterment of the patient. But here comes, how do you apply the algorithms? How ethical are you going to be in applying the algorithms? Are you going to be meticulous and you will apply the algorithm that way? Or just because the machine sits there, are you going to switch it on and put it on every patient there? That's where the ethics and the application of ethics comes into play. And this is another reason why I'll have to apologize to you. I like to take pot shots at management people because I'm a technocrat. So that is why you will find that in India, there is no multi-speciality hospital which has got a thriving ophthalmology department. No, you can look at it. No way. Any thriving ophthalmology department, except maybe 1 or 2 in the whole country, is only on an individual standalone ophthalmology unit. The reason being, if all these multi-specialty hospitals are managed by management specialists. So when the ophthalmologists say, I want to buy a machine for 1.5 crores, so that person will sit down and do a calculation. What is the number of patients see per day? 100. Out of that, how many are diabetics? Or 20. 20, how many are you going to put on this machine? So what is the returns you're going to get? And that's going to look pathetic. They say, no, it's not sanctioned. While in an ophthalmology setup, to me, this machine does not look at only diabetes. It looks at so many things. So when I start using this, my overall practice changes. So we don't look as ophthalmologists as an individual specialty practice. I'm not saying individual practice. There are large ophthalmic hospitals which will go into this without any fear, because this machine standalone, if I were to look at the costing and the way that it's giving me money, may not meet even probably will meet the interest payments, maybe a little bit of the principals, but then it's the end result. The number of patients who are diagnosed, what they go for another procedure, where they go for surgery, or where your surgery becomes more safe, your results get to be superior. So overall, we look at it, and then that's how the whole system changes. So that's another point where we should look on an overall department, what it would do, not as individual cogs of the wheel. So that kind of an application is not going to work. So sensitivity, specificity, again, we look at it. This is highly sensitive, highly specific, but unfortunately, you're going to only catch 20% because the prevalence is only 20%. To catch the 20%, you have to keep testing the 100% of the patients on this. So that's what I said, it comes to the cost. So the cost of getting this kind of a treatment, test done, depending on the center, would be anywhere between 2,500 rupees to 5,000 rupees. So, but I like to put it in one way that if you have a Maruti car, the cost of insuring that is about 12 to 18,000 rupees per year. That's probably the cheapest car on the market. So why don't you insure your eye for 2,500 rupees a year? But unfortunately, we don't have only the eye. We've got so many other organs in the body. How much insurance are you going to do? And again, unfortunately, the insurance, medical insurance in our country does not cover OP procedures, does not cover investigations. While in the US or the Australia or any other developed country, it is not only surgeries, but the visit to the doctor is covered. But the double side of the sword would be that once you do that, your premium is going to shoot up. The number of premium paying capable patients or population still is low in India. So this comes to a sobering thought. Though one can make fun that money only the technology follows money and so on, eventually it's just that you have to have the finances to do anything. A very sobering thought. I'll tell you why. We have Indian population is about the same as Chinese population. 2 decades ago, both were considered poor countries. So we'll take one single thing. We'll take up refractive surgery, LASIK or SMILE. SMILE is the most advanced. Okay? In SMILE, India has been having the SMILE technology for about 10 years. Total number of SMILE machines in India are about 35. Okay? And when I bought the first generation SMILE machine 8 years ago, mine was the fourth machine in the country. And the new one that I bought, the upgraded version, SMILE Pro, mine was second in the country. Fine. It all looks good. But look at China. They have 550 machines. That means their GDP is running the engine. It's turning it. Okay, again, we'll have to have the other side of the story that the Oriental race has got more minus power than anybody else. So the huge number of people agreed. But that's the second point. Third, I was there about 8 weeks ago in Singapore for a users meet. And we have this Chinese guy coming up there and making presentations, poor in English. And the numbers of surgeries they run are mind-boggling. And what really puts the scale at an even keel is they charge 2.5 times what we charge our patients. And the population pays. So finally, whatever we want to do in technology, technique, delivery of anything to the person, there has to be finances. And that can only come as our GDP keeps going up. So we should, of course, I love to make fun of money and management and management people, but that is what drives. That we have to accept that. It's nice to crack a joke once in a while, but that's the truth. How it's applied and how we do it is what is going to change the scenario. I look forward to a point where we at least match China to about 20%, not even 50%, in the next 5 years, and then we are going to be in boom time. So glaucoma. What is glaucoma? Increase in pressure of the eye. The eye is a fluid-filled structure. There is continuous manufacturing or secretion of fluid, and that's slowly going out through another pathway, and the balance between the two keeps up a certain pressure. That pressure is normally somewhere between 12 to 18 millimeters of mercury. Anything higher is not good. Lower is not a problem, but too low is not good at all. So when it goes higher, what happens? It just goes into a pressure effect. Simple, we look at the optic nerve. This is the optic nerve. The cross-section shows a small dimple. That's normal. As simple, we'll just take out all the science and everything and go into simple. Pressure increases, it's going to push on this and it's going to bulge. So this starts to bulge backwards. So you see the dimple that was here got large and got depressed. So that's where the central dimple got enlarged. It's completely enlarged. What is the dimple? That's where the nerve fibers that are coming in, millions of them coming down, are going out through the optic nerve back to the brain. So as this pressure keeps pressing on the nerve fibers, they keep dying out. So this whole dimple starts enlarging. As slowly the patient is losing vision on the sides. Central vision is still good, so he or she does not know that vision is being lost. So this is very advanced glaucoma. So how are we doing this diagnosis? So how does somebody get glaucoma? Most of it is genetically predisposed. If one person in the family has glaucoma, the siblings having glaucoma is very high. Chances of the next generation is 50% lesser, but it's still there. So such are the people that have to be screened for glaucoma. But whenever you go to the ophthalmologist, whatever your age is, unless it's a toddler or a small child, pressure is always tested. And the optic nerve is always tested. So it's easily caught as long as you make a visit to the doctor. So when this is difficult to see, I don't know if you can make it out, this small dark band there. It can be seen, isn't it? That's the band. That's where the nerve fibers are died out by pressure. This optic the pit is enlarged. The same thing, red free is more clear. So in eye, everything is upside down. When you lose fibers on the top, you lose vision at the bottom. So when you do a test called field test, the person cannot see the lower half, but can see up and look straight. So he or she may not even know, because other eye is seeing well, that they go down upstairs, they'll have difficulty. Otherwise, they may not even know that. So this was the diagnostic tool. The gold standard was field test. So coming back to prevalence, next to cataract, this is the most common blinding disorder in the world, present all over the world, and in the darker skin races, more prevalent, particularly because our irises are thicker and more pigments, and we are more prone to glaucoma than a lighter skin race. This is how we used to look at it 30 years ago. This is how we look at it today. When you look at the optic disc directly, and when you want to do a field test, this was what was done 30 years ago. Now we have a computerized field testing machine, but that's pretty much cumbersome, particularly because most of the patients have glaucoma are in the 60s, 70s, and 80s. Stick your head into it, and there's a light that keeps falling at different points, and you keep clicking yes or no. And the machine also tries to fool you into giving false positive, false negative results to evaluate whether you're a good candidate or not, whether you've done the test accurately or not. So it can be quite confusing, and accurate results are sometimes difficult. So how do we diagnose glaucoma early? With OCT. You can actually count the number of cells. You can count the number of nerve fibers and give you a graph, give you an algorithm that says you've got glaucoma, you don't have glaucoma. So this is how it looks. This is a person whose field test is absolutely normal, but you can see, I don't get the point. There comes a pointer. Small area which shows red, the nerve cell, the cells count is low. Yellow, it's slightly lower than normal. This rim shows that at this point, the nerves fibers are thinned out. And that's a graph that shows if the lower part nerve fibers are thinned out. But you know this person has glaucoma 100% because we got the OCT, but the field test would say normal. So if you didn't have the OCT, this person would not be diagnosed as glaucoma. So OCT can catch glaucoma 1 to 2 years before the person comes up with a field defect. You can look at the enlarged blood vessel dropouts. When nerve fibers die out, the capillaries also will die out there. So this is one point that also can be caught. So you have here completing a nerve fiber loss. You've got angiographic loss. This can be seen very clearly. So this is early glaucoma caught very, very early. So again, highly sensitive, highly specific. Very tempting to use it on whole number of patients, but then we would like to look at patients who have funnily shaped discs, age above 45, family history, and then put them on this. Here again, there would be a large number of patients who would come out as negative, which is good. But then this person has got a suspicion of glaucoma. He or she needs to get these tests repeatedly year on year. So that's again a burden on the pocket. But there's no excuse for that. We have to do it. So you can catch glaucoma almost 1 to 2 years before it shows up on the field. We'll go one step forward. This is just my final few slides. We can go with electrophysiology. So we told you cells die out, I can count the cells. Nerve fibers die out, I can count the nerve fibers. Angiographically drop out of capillaries, I can get it with angio, and then I can make a diagnosis. But lo and behold, we can now catch it 4 years before by looking at electrophysiology, something known as ERG, electroretinogram. Electroretinograms have pretty much been there for 30, 40 years. Nothing great about it. But very expensive machines, very cumbersome to use. You have to put multiple electrodes, and you have to put an electrode on the eye. It's like a contact lens with a wire dangling out there, and it will take all of 30, 40 minutes. So the patient is really feeling uncomfortable when you'll get the results. So, but now you can do the same electrophysiology with just 2 electrodes, one there, and a single one that goes upper lid and lower lid. Just stick it there, and you get the ERG. And it's fantastic. Again, It doesn't give you just the raw output, it gives it to you on a number and a color scale. This is normal. On the other side here, it shows in red, this person has got early glaucoma. If you follow him up after 4 years, he will develop visual field defect. So this is the way that diagnosis is going on. But then again, how do we apply it? How many patients do you put it on? And how do you go around making early diagnosis? Another point is, yes, I have this patient sitting across my table. 4 years from now, he is going to develop overt glaucoma. Do I start treating him now? Do I just keep following up for the next 4 years? Is he going to come back? Painless disease? After 2 years of paying me 5,000-6,000 rupees every time he comes and sees me, he's going to get fed up and not come back, and probably come back after 5 years with advanced glaucoma. So there are a lot of issues that come into play here. So finally, all of it boils down to applicability of a particular test to a particular group of people, how to apply it, how to make it cost effective. There's only a particular level to which the cost effectiveness can be done by the doctor. Finally, it is what the paying capacity of the general population has to increase. You can't expect everybody to pay upfront. How it's going to be done is a question to be answered. The simple thing is, economy improves, everything improves, health improves, wealth improves, everything improves. So that's where it comes down to, cost. Eventually, everything. So summary, advanced technologies available for early diagnosis of potentially binding diseases. They have high sensitivity and specificity. They are totally safe, non-invasive. They are rapid tests. It's not going to take you an hour to do this. All these tests take less than 10-15 minutes. So it's very, very rapid, very, very, I wouldn't say it's completely comfortable to a patient, but it's no great discomfort. So these are the tests that can be done. This is how it's going. Now we'll come to the last few sentences I want to speak before I close. Artificial intelligence is coming in. So as I told you, the retina is the only place where you can look at the blood vessels. And you can now see how blood is flowing, everything is available. Now if you have millions and millions of these photographs and data as to that particular person's BP, sugar, whether the person has developed cardiac problem or not, all these data, which is only by history. And if you give this to the artificial intelligence is now able to compute minuscule, micron level changes on the retinal vasculature and predict a person who is going to develop renal disease, cardiac disease, neurological disease. Very, very exciting. Google is working on this. We're going to get this out very, very soon. But how it's going to come and which way it's going to come? Are we going to go to the mall, go for a movie, come out, go into a kiosk, stick your face in somewhere, and that's going to take a photo? That's all it takes. These cameras are fantastic. They can take a photo without any drops. Unless the person has got advanced cataract, it can take a photo. And this high resolution photos, the artificial intelligence can analyze it and then give you a report. Then you have to come to the doctor anyhow. So cost to doctor, cost to patient is what finally matters with all of these technologies. Thank you.
Check. Ladies and gentlemen, would you like to ask some questions? Otherwise, I have from the online viewers.
Yeah, good evening, doctor. A fantastic session. I'm RS Mani here. So slightly you are fearing us also, telling the cost is very high for the treatment. I also have like a suggestion, no? Like you told that OCTA equipment is very expensive, like it may shoot to 1.5. Like there are a lot of scan centers available on heavy equipments, scanning and all those, no? Why not for ophthalmology having a scan center in common where they can go and take the report and come and take an advice of you? That may reduce the...
No, there are centers like that in Chennai itself.
Okay.
That does not make it any cheaper. It does not put the cost on me. It puts on the cost on a group of people who are investors into that. But it does not reduce the cost to the patient eventually.
Okay.
That's what I'm trying to imply. that costs will come down slightly, but what we all have to work towards is increasing the paying capacity of the general population.
Yeah, that I.
That's what is going to work. We can work a lot towards, the government can buy this and try to give it free to the patients. That is not the way to go. The way to go will be that it has to get better, where the persons can be able to pay for it, either by the earning capacity going up or by insurance doing a better job.
Okay, so this OCTA equipment is available in some common scan
Yes,
centers
yes,
also?
plenty. That's there all over the country.
Okay,
That's not a problem.
thank you.
Yeah, can I take on some questions here or? Yeah. See, doctor has been emphasizing that if the GDP goes up, then the treatment can be better. One way to increase GDP is that all of you must attend MMA programs regularly. Doctor, some of the questions here. The first question is from Shushma Trichy. She's asking you whether can cataract be prevented?
Cataract is an aging process. It presents at a variable age depending upon the race. For the Indian race, between 65 to 75 is the most common. It could come earlier, it could come later. But the point is, you cannot prevent cataract, because I hope cataract can be prevented and the technology or the science to prevent it comes in my lifetime. Because if we can prevent cataract, which is the aging process, we can prevent all other aging processes, I can live forever. But as of now, it's very difficult to say so. But again, if a person is taking enough antioxidants, because aging itself is an oxidative damage, they can prolong or delay aging to a certain extent. So yes, cataract can be delayed. It can't be prevented.
Yeah. There's one more question from Mr. Nainan Erode. He's asking you whether yoga helps in preventing eye diseases and ailments like cataract, glaucoma, etc.
Yoga will make you healthy. Better health would reduce a lot of diseases. But I don't think yoga is going to reduce the chance of developing cataract or treat glaucoma. No, I don't believe so.
Yeah. This is from Babura, Chennai. He wants to ask you if, can you share with us any recent breakthroughs or innovations in ophthalmic diagnostic technology that have further improved the sensitivity and specificity of detecting eye issues? Eye pathologies, particularly in India.
No, because all of these tests have very high sensitivity and specificity. Otherwise, they will not be in the market. Something that's on a low specificity and sensitivity does not find place in the market.
Yeah, he wants to know about any more breakthroughs in this.
Plenty are coming through. As we speak now, the OCT is something that is applicable for multiple diseases. It's coming up to a higher level and higher resolutions. So you can now go down to 1 micron, so you can catch diseases even earlier.
3-4 more questions. How safe is it to do eye testing in optical retail outlets like Lenskart or specs makers? Is it safe? Why does the government permit this?
Okay, then it comes to a completely different question. Is it safe? Yes, it is safe. You can't get into any trouble because of that. Because testing vision is one part of testing the eye. Vision testing is only one part. So if you come to the doctor, the vision will be tested, intraocular pressure will be tested, the optic nerve will be looked at, and all the structures of the eye would be looked at by the doctor. And if anything is not all right, then further tests would be done. So you're stopping at the first level only. So eye testing to get glasses, there is no risk in going to a particular place. But imagine a person has got early glaucoma. This kind of a optical outlet will not be able to diagnose early glaucoma or early diabetic retinopathy. They can only tell you when the vision is not normal. They will tell you the vision is not normal, you're not reading the last 2 lines, go see a doctor. But then it's too late. So it would be much better to visit an ophthalmologist and get a proper eye test done, particularly in anybody over 40 years of age.
Thanks, Doctor. This is from Lakshmi Varun, Chennai. What is your advice on use of contact lenses? How often are they to be changed?
Okay. Contact lenses are safe. Dirty contact lenses are unsafe. Lenses get dirty because the person who's using it either has not been trained to maintain it well or has become lackadaisical in the maintenance. That's where it starts to go haywire. Usage of the lens, most lenses today are throwaway lenses. Usually we prescribe monthly disposable lenses so you can use the lens for 30 days. Don't overuse them beyond the term that it has been indicated for. Using a monthly disposable for 3 months, 6 months would go into risk. Maintaining it in a proper way, maintaining the case to be cleaned, dried out every day, and fresh solution put in every day, then you're quite safe. To be 100% safe, you've got daily disposable lenses come in, they're a little expensive. Put it on in the morning, evening, take it, put it in the dustbin, go for the next lens next morning. That's absolutely safe. But long term, somebody who's going into contact lenses has got a reason being that he or she does not want to wear glasses. They are motivated not to wear glasses. Imagine a person who's 18 or 19 or 15 wearing contact lenses. Is it anyway possible that that person is going to use lenses for the next 50 or 60 years? No. Contact lens is a temporary solution. If you're looking for temporary solution, go for contact lens. If you're looking for permanent solutions, go for laser refractive surgery.
Thanks, Doctor. Yeah. So the contact lens is disposable, but the eye is not disposable. So there's a question from a teacher from Salem. Her name is Yashoda. She wants to know, with the increased use of computer, mobiles, and other devices, what kind of impact it would have on the present generation.
Okay, this is going to take about 4 minutes to answer, so get ready. The common misconception is that we are having rays coming off from cell phones, laptops, and computers that are spoiling the eye. There's even one YouTube going around telling that you keep looking at it, you get cancer of the eye. Impossible. There are no rays coming off from any of these products. That's one. All over the world, myopia is on the increase. There's no doubt. That means minus glasses on the increase. No doubt about that. Why is that occurring? One of the explanation is that evolution-wise, we were hunters and we were always looking at the distance and looking to forage or to hunt or to do anything outside, where the distant vision was more important. Vis-a-vis, over the last maybe couple of 100 years, we're looking at more and more near activity. So when you are doing more near activity, if you're a myope, you can see better without glasses. So the easy way of saying that evolution is bringing in myopia. So more near vision, more near work, the theory says they will have more people with myopia. You can't wish away textbooks, you can't wish away laptops, you can't wish away computers, we're going to look more near work. How do we counter it? It has been proven that at least 1 to 2 hours of natural sunlight exposure to a growing child reduces myopia. So, in a country like Singapore, where they have a large Chinese population and large myopia, they try to have at least 1 period a day under the tree. This is what used to occur when I was a kid in school in the 60s. So that's coming back. That does help. And encouraging kids to go out and play more, exposure to sunlight can be a third. Why does a doctor normally say, don't use a cell phone too much? Because it being small, you bring it closer. Even if you were to hold your textbooks this close, it's not good for your eye. That causes more stress and strain on the eye. It's not going to lead to blindness. A lot of stress and strain on the eye. So you want to keep it at a distance. Automatically, cell phone being small, you bring it close. So if you have to work on a cell phone or on a computer or on any electronic device, please do it on a laptop or on a desktop, less on cell phone, because you tend to bring it closer. You won't bring a textbook this close, but cell phone you do. That's the only thing. So nothing else to it. There are no rays coming out and it's not going to go. We have to learn to live with these products. So one other point is, all of us are going to use computers a lot, and people who are on the software industry are more. There's a 20-20 rule for that. Every 20 minutes, you don't have to get up, stop working, look up, look at the distance for 20 seconds. That's all we want you to do. Every 20 minutes, look up, look 20 feet away for 20 seconds. then come back. So that will make a lot of difference. This is one of the things that ophthalmologists advise the patients to follow, or people who are in the computer industry to follow.
Thanks, Doctor. This is from Yamini Mohan, Chennai. It is said that patient education helps in maximizing the benefits and treatment, particularly in eye care. How does your hospital promote this? It's a very personal question. If you can answer, it's fine, but...
Absolutely. We have a whole bunch of YouTube videos, Instagrams that we keep putting out, which are patient education. That's the easiest way to reach out to the population now. Once upon a time, I was writing in newspapers or magazines or giving TV interviews. Well, they don't work anymore. The whole community is more on YouTube, and even YouTube has become old, and Facebook has become, for the older generation, Instagram is new. So our presence there is quite significant.
Yeah. Two more questions, Doctor. One is from a HR manager. Wants to ask you, in Pondicherry, an organization can treat the eye problem through simple 2-week session with ball and oil. Is it worthy to take the session? I don't know what.
Okay, that's right. I know about it, and 25 years ago, I've sent my people there to get trained for 1 whole month, and we try to replicate it here. No, none of these exercises can reduce the glass power. Let's be very clear. But these exercises really do wonders for non-specific discomfort a patient has got, non-specific eye pain, non-specific headache, eye strain. It really works wonders. But please, it does not do 1% reduction in glass power. There's no harm in doing these exercises. They probably do you some good. But if your aim is to reducing or getting rid of your glasses, it doesn't work.
So, one last question. It's from a person in Vellore. What are the potential challenges or limitations associated with relying solely on sensitivity and specificity when diagnosing eye diseases?
No, you're not relying on sensitivity and specificity to diagnose. You're relying on these two criteria to apply a diagnostic procedure onto a patient. So, you're very, very clear. If the sensitivity and specificity is less than 90 or 92%, then that whole test falls flat unless you develop algorithms which can predict to higher levels. So you will not have unnecessary tests being done, and you will not have false positive and false negative results.
Thank you, Doctor, for answering all the questions so patiently. But two more points that I wish to tell you is, Doctor is a black belt in karate. Many people around Ananagar know him as a great karate black belt person. And the second one is, when I went for my surgery, doctor told me, look at me. I said, doctor, if I can look at you, I wouldn't have come to you.
Yeah,
Thank you.
Thank you. Ladies and gentlemen, got a question? Okay, just give the mic.
Thank you, sir. Good evening, doctor. I have a simple question that how safer is LASIK? How safer is LASIK? And I have seen a lot of ophthalmologists wearing the glasses. If it is a safer and advanced, why not doctors themselves do LASIK?
I'm wearing glasses. That's because it's for reading. Anybody over 45 needs to wear glasses for reading. LASIK works as of now. There's a close to 99.8% success rate for distant vision, not for reading. So that's why most doctors continue to wear. So to put it in perspective, my daughter-in-laws have LASIK done by me. My daughter has had LASIK done by me because both had glasses. So unless it was safe, I would not have done that. LASIK is very safe as long as your cornea is fit to undergo the treatment. LASIK is about 30 years old. Now we have got something more advanced called SMILE, which has taken out all the small niggling issues in LASIK which are there, are removed here. So it's becoming even more safe.
Thank you.
What is the average cost for
LASIK can vary anywhere between, depending on the technology that's used, anywhere between about 50,000-60,000 rupees to 1.5 lakhs, depending on the different technologies that are available. LASIK, petro LASIK, customized LASIK, SMILE, so there are different things.
Thank you, Doctor. Fascinating evening. Thank you, viewers, for asking so many questions. And some points which really inspired me is the doctor said 20/20 is there everywhere. Even eyesight, you have to be depending on 20/20. That means 20 minutes. Please remember, when you are working on system, 20 minutes 20 seconds. And I'm looking at my guys. My guys will say, doctor said 20 minutes you'll be away from the computer. Let me come back after a walk. No, it's only 20 seconds. You look at something distance. Then he also said AI. Why I'm telling you, we are having a full session in our AI conference, which is happening on 28th. What is the impact of some of the technology on in the field of medical science also? So it's, I think AI is really taking over many areas, not only in the field of our corporate world and automation and manufacturing, even doctors. I think AI is going to be a great tool of help to them. Ladies and gentlemen, put your hand together to Doctor for a fascinating evening. And I also thank over 700 viewers who have watched this program live from various things. If any of your friends missed it, please share with them. And I think everybody should know what's happening in this area. That's our objective of bringing some outstanding personalities in the area of different fields to come and share their insights. And thanks so much. And thank you for being with us. Keep coming to MMA events. If you're not able to come, watch it from your home comfort. As a token of our appreciation, I request Kumar to give something which is really sustainability. Doctor will love it. Can you? Revenue for a